Mayo Clinic presents
Emergency Medicine Grand Rounds.
Welcome to the January Grand Rounds edition of the Always On EM podcast. My name is Venk Bellamkonda. I'm one of the hosts of the show. Dr. Alex Finch is the other, and he is probably the better of the two. You probably have noticed that we revamped our podcast logo, but you may not have noticed that we're also on YouTube Music. Both of these are new changes as of the new year, and we're already reaching a whole new group of people, which is truly awesome. I'm also stoked to share this talk with you today. The speaker is someone I have known for a very long time, and she is one of the most intelligent and accomplished people I have ever met. Dr. Lekshmi Kumar and I met in 2006 when she was a research fellow at Mayo Clinic and I was simultaneously a psychiatry intern. We became residency classmates in emergency medicine in 2007, and I began to see firsthand how caring she is with her patients, how brilliant she is with the science, and how awesome she is with her family. They're pretty awesome too, I have to admit. She has gone on to become the EMS director of the city of Atlanta, which is really one of the toughest jobs I can imagine. At the same time, she serves so many people through everything she and her entire team of incredible people do. And it's for this reason we wanted to hear more from her. So we invited her back to talk through how they recently implemented a blood transfusion program successfully in the pre-hospital setting. I hope that you can take away some of the ideas on what you can do to overcome challenges in your own community, even if it's not about blood transfusions, or if your particular area of interest is not EMS. I think the method of approach to tackling a big picture challenge with many different stakeholders and logistical challenges, it always has learning points. To give a more formal introduction of Dr. Kumar is our own EMS director and an incredible physician leader in her own right, Dr. Anu Luke. Take it away.
It gives me great pleasure to introduce our speaker for Grand Rounds, Dr. Lekshmi Kumar. She's an associate professor of emergency medicine at the Emory Grady system, and she's been there for the last 14 years.
Ever since I left here.
Yeah, she graduated from here in 2010, along with Dr. Bellamkonda and Dr. Sunga. They were in the same class. And then she went in to do an EMS fellowship at Emory. She has been a medical director for both fire and EMS and is currently medical director for Grady EMS, which is a huge system. In fact, every year she gets invited to a special conference for all the big EMS systems that's called Eagles. So it serves the city of Atlanta. She's actively involved in biosafety transport team, both education and training, and serves as part of the National Ebola Training and Education Center. She also serves as the medical director for athletic events such as the Atlanta Marathon. She's passionate about pre-hospital education and is very well respected in the EMS community nationally. I believe you left out that you were actually co-chair of one of the committees as well in our national body, NAMSP. So.
I served my term.
And she's a dear friend that I get to see every single January at our conference. So welcome. You're going to talk to us about pre-hospital transfusion.
Thank you so much. I'm so glad I was invited back because coming back to Rochester it's like a blast from the past. It was fun to walk around and see familiar faces and new. Like Anu said, I've been doing EMS in Atlanta, Georgia for 14 years, and I finally took over for Grady EMS, which is our 911 response system for the city of Atlanta. So it's a pretty massive system, and I took over right before the pandemic in 2019. So my predecessor, big shoes to fill, Dr. Yancey, retired. I don't know how he timed it so well. He retired and 3 of the floors of our large county hospital went underwater. There was a pipe main burst and there was a lot of logistical EMS challenges. And then the pandemic happened and then there were the hostilities in Atlanta and the riots. So it's been one thing after the other, and I still have to figure out what a normal day looks like. So this is one of the initiatives that we started when we did have like a few months of normalcy in the middle there, right when we were recovering from the pandemic. So I just wanted to kind of share our experiences and talk a little bit about how we manage trauma and how we try to like extend that management into the pre-hospital setting. So no commercial relationships, financial disclosures, or conflicts of interest. None of the products that I've mentioned here, we're only mentioning it because we're using them. I have no ties to any of them. So objectives will kind of briefly touch base on the physiological benefits of early hemodynamic stability in trauma patients and kind of identify what the key pillars are for a successful kind of pre-hospital whole blood program, because it is up and coming, and there are hospitals that have, or EMS services that have started that in the past few years. And we'll outline like the essential components that are required to establish a system like this, mostly talk about our experiences and how we kind of establish this within ours. And hopefully some of this you can translate to your system. Some of it might not be applicable, but it's a good kind of review of how to make something work and what the pillars are for, kind of putting this thing together. So just a background about Grady EMS. So we are located in Region 3, which is in the center of Fulton County. That is basically the city of Atlanta. So it's a city of Atlanta and South Fulton, and it's almost all the city and a little bit of the surrounding areas. Within this area, Grady, which is it's a county hospital. It's your safety hospital for the community. It is a large hospital. Our ED visits are around 160,000 annually and growing. And we are the only level 1 trauma center in the city. So we did have another trauma center, but they shut down right before the pandemic. So that was also part of the challenge. Population is growing, hospitals are coming down, and we were the only one, which worked out great for our program for the blood, actually, because we knew all the patients who were receiving blood will end up in our trauma center. So it was easy to kind of track that. We do dispatch our units through MPDS, and basically what this is if anybody in Atlanta calls 911, they pick up the phone and they're like, oh, it's medical, they send it to Grady. And when we pick the phone up and we are trying to triage them, and we go through the same kind of processes that you guys go through, and we come up with a code, a dispatch determinant. And so we can decide early based on certain dispatch determinants if we want to send a unit out to give blood or if it is going to be a major trauma. So it's a very similar system. Our area coverage is around 360 square miles, and our population is 700,000 and growing. And that's just like the population in Atlanta during the day, all the suburbs, everybody who comes in, we grow to 1.5 times that just during, office hours. We are a tiered system, which basically means our ambulances are not all ALS. Like, we don't have a paramedic in every ambulance. I wish we did, but there is no way we can support that, especially after the staffing shortages of the pandemic. We've got some trucks that are basics, some advanced, some ALS, combination of these. And that's important as well, because a lot of times for trauma, who are we sending? We don't necessarily need ALS. For trauma, it comes down to your basics. So a lot of times we're sending these advanced trucks. And our annual call volume within our EMS system is close to 150,000. And we usually, during the day, we have anywhere, and when we say 35 to 40 units, that would be a good day. We don't have 35 to 40 units every single day. I wish we did. We probably need that many out there, but around 30 trucks to staff the city at any given time. And we kind of go down during the night to 20 something. So it's a fairly large system, but similarly structured. It is a hospital-based system. Not very many hospital-based EMS systems around in the country. Grady is one of them. I'm going to say Gold Cross. I know it's not Gold Cross.
Mayo Clinic Ambulance.
Mayo Clinic Ambulance is one of them. There's very few left, but there is definitely an advantage to having a hospital system when you're trying to institute a program like this. So let's talk about a patient. So this is an actual patient that we had after we instituted this program, right? So a 34-year-old gunshot wound Friday night. I moved from Rochester, Minnesota to Atlanta, and realized I went from a very controlled environment to a complete gun and knife club. So we have a ton of penetrating trauma. And less, we do have blunt trauma as well, but majority is penetrating. And so this guy had 2 penetrating wounds, one to his upper left, 2 to his upper left thigh, and 1 into his chest. They call 911. PD showed up there, and so did fire. And our PD, similar to here, you guys, every PD has an AED, every PD carries Narcan, but with the amount of trauma that we have, they also carry tourniquets, and they're trained to use tourniquets. I mean, sometimes we get there on scene, and if it's somebody who's new, they haven't applied it correctly, we might have to reapply, but they try to do tourniquets on scene if they can. So PD had already applied tourniquets. Fire showed up. They ended up putting chest seals to kind of contain the wound. And by the time EMS got there, the patient was lethargic, diaphoretic, tachycardic, and hypotensive. So essentially, patient is in shock. And most likely, what kind of shock? Hemorrhagic shock. So it's fairly straightforward, right? And so these are just some statistics to think about, right? Traumatic hemorrhagic or traumatic hemorrhage is the leading cause of death and disability in younger adults. And it's the leading cause of preventable death, both in a civilian setting and in a military setting. I mean, it's preventable, and we want to try and decrease, especially given it's one of the leading causes. Annually, it accounts for 60,000 deaths in the US and 1.5 million deaths globally. Those are some staggering statistics. And the mortality in adults within 24 hours is 20%, and in kids, it's almost 25%. So we're talking about 1 in 4 kids, if they have traumatic hemorrhage leading into hemorrhagic shock, will pass away within 24 hours if they're, serious. And the sad part is more than half of these preventable deaths that are due to hemorrhage, most of them happen before they even get to the hospital. We don't even see them. So 85% of those that die are dying before they hit the hospital doors. And there's nothing we can do. So it's one of those things with trauma, it's always been, we need to get them to the hospital to definitive care as fast as possible. And the ones that make it have half a chance, and the ones that don't, unfortunately, they don't, right? So we've always tried to optimize how we treat hemorrhagic shock. Initially, it was crystalloids. And there have been people who've moved to plasma PRBCs, and now it's whole blood. So we actually, in our ERs, we have whole blood down in the ED in our trauma center to give if there is a patient that comes in with major trauma. But what we want to do is do it as early as possible, right? What our trauma surgeon says is, like, we went into permissive hypotension because we didn't want to dilute the patient and give them too much of fluid. He'll come down and he'll say, well, there's one of our older trauma surgeons, he'll be like, stop giving them pasta water, just get the blood out. And he calls it pasta water, and it'll stick to all of us, right? And we're like, okay, we'll stop the pasta water and give whole blood. So we actually have it down in our trauma center. But how many of our patients actually make it to the trauma center was the big issue. So we were like, we think it's a good idea to give them blood and to give it early. And there are centers that are doing it. And we're like, okay, I think we should do this. We know that it improves survival, right? Early administration of blood. Time is a factor. It is a component. It needs to be done earlier rather than later. It does maintain your perfusion, oxygenation, and reduces your shock and your organ failure. So it does help. And it's been studied and used in the military setting. They use it. And it's worked in the military setting. Translating anything, a lot of stuff in EMS ends up being, taken from the military setting to the civilian. And there is that amount of adjustment that we have to do for this, but we know this works. But why have we never done this? Because it's a ton of logistical challenges. I mean, getting blood out onto the scene is not easy. Transporting it at a certain temperature is not easy. How are you storing it? How are you, everybody can walk around carrying blood. It's not easy to get it to the patient, depending on where the patient is. HEMS, or helicopter EMS, has always been better at this because they fly out to scenes. When I was a resident here, we used to carry blood on Mayo 1, and we would fly out. If it was a trauma, we would immediately pick up the cooler and put it on the helicopter and fly out to the patient. But getting that to happen on ground is not an easy task. But we knew we wanted to do something like this. So we looked at resuscitation guidelines, right? In pre-hospital trauma resuscitation, it has always been, the patient doesn't need to be here, they need to go. EMS has evolved a lot where we do things on scene and we try to optimize and we do as much as we can on scene. But when it comes to trauma, it's always been load and go. We need to get to definitive care. Don't do anything, just move. And that's always been and it's true. Grady does sponsor a NASCAR car. I'm pretty sure emergency medicine and trauma were not consulted when they did this. I was surprised. Actually, none of us knew that they sponsored a NASCAR car, but they do. Clearly, infinite source of business for us. But we try to transport them to the hospital as soon as possible. So we looked at our statistics, like, do we need this within our system? So that was our first step. We have to look at the data. If our data shows that we don't need it, please don't spend time and effort putting this in place. Fernando will be proud of me for saying that. So look at the data first. And we looked at 2023 data before we started, right? How many trauma calls did we transport? So within Atlanta, and we split up Atlanta and South Fulton for a reason, because geographically they're covered in a different way EMS-wise. And we wanted to make sure that we did not, if we were deploying resources and blood, do we just do it in Atlanta? Do we do it in both Atlanta and South Fulton? Because it's a little bit logistically challenging to do both. But we looked at total trauma calls, and we had around 15,000 trauma calls within the year of 2023. Now, what makes this challenging is how do we decide which ones are critically higher acuity, which ones are the ones that would fit the bill of needing blood, which ones are the ones that are really sick. Now, the problem with this is this data is only as good as paramedics put in. So if they don't document that the patient was really ill, we don't really have that data. So because some of our electronic healthcare record system for EMS, it's not all mandatory fields, and it depends on how good the documentation is. But we tried to do as best as we could. We looked at how many were transported lights and sirens, how many had a systolic less than 90. We chose 90 because that was going to be our criteria. And we also looked at average scene time, because we didn't want anybody to say, oh, you're giving blood and now you're sitting on scene forever. They're not getting definitive care and you're wasting time. So we wanted to make sure that we don't extend our scene time just because we're staying to play and do other stuff, because we know the definitive care is still important. We looked at procedures that were done just to kind of estimate, are these people sick, are these people not? We looked at how many tourniquets, how many decompressions, how many chest seals, to kind of get an idea. So we got all this data, and based on this data, we were like, yeah, I think we should do this within our system. I think there is the need. I think there is the want. And we started discussing it with a key stakeholder. So I reached out to trauma surgery first, and they identified a trauma surgeon who they thought would be a great champion because he had some background in EMS as well. And he I reached out to him. I was like, Dr. Fransman, we would love to do this in EMS. We want to make sure we have a surgical champion to help us out with this. And he replied and he said, they gave me an offer letter, but I don't even move there to Emory until August. And I was like, oh, I'm so sorry. It's only March. I'll wait till August. But if you need any help while you have to move, let me know. I can, recommend where you need to stay. And he was like, okay. Reached out to him twice more in that period. I was like, are you here yet? What's your time frame? Are you still coming? So really pushed it, but he was all for it, which helped us tremendously. So surgery was on board. EM, of course, was on board. And then it was lab and transfusion medicine. I was fairly certain that they would say, oh gosh, no, but they were like, sure, we're happy to let you guys try, which totally baffled us, because a lot of hospitals, we talked to a bunch of EMS systems before we started this, and a lot of them, their stop was blood banks, because a lot of them are not hospital-based and they're approaching private blood banks too. So it was really hard to get that contract or that MOU going. So we were surprised when our transfusionist said, yeah, that sounds like a good idea. So we're like, perfect. Let's, decide what equipment we are going to carry. Let's get everybody in the room together, talk about this, what this is going to look like, and what paperwork is needed, because blood bank equals lots of paperwork is what I've learned. And there's no way around it. You just have to embrace the fact and make sure you are doing it the right way. And essentially, we went down all the way into a year down the road when we started training our providers. And that initial round, we trained around 75 of our personnel, and some of these were fire personnel as well. And we decided we'd go live on March 17th. It was St. Patrick's Day. We had to pick a date, any date. That's what we chose. And we did not give any blood till March 21st. So we were waiting there. We're like, oh gosh, we are just not going to give any blood. I guess there was no need, because it's really hard to kind of gauge that from prior numbers. And after the 21st, it was like the floodgates open. We gave so much of blood. I was surprised. It was more than we anticipated. So if you talk about like setting up a successful pre-hospital program, there was a paper that kind of came up with these 4 pillars on how you would kind of go through and set a good one up. And your first pillar was establishing that rationale for use, right? And describing what you're going to do, how you're going to give it, and how are you going to translate that into your pre-hospital system. Your second pillar, how are you going to store it, move it, the logistics of it. And your third is your transfusion criteria. What are your protocols going to look like? Who are you going to give it to? Who are you not going to give it to? And of course, your fourth pillar, your documentation and your handoff. So let's go through our program and how we kind of did it within each pillar. So we already have the rationale for use. We decided, yes, we need this in our patient population. So then it became a question of what are we going to use? So we decided to use low titer O positive whole blood. So this was our decision because we already had low titer O positive whole blood in our trauma center, and that's what they were giving for our trauma patients. So we just try to pick that up and extend that out into EMS. It's low titer, right? So low IgM, IgG, anti-A, anti-B agents, so less than 256-ish is what they say. And what they found is that the numbers of reactions that you can get from low titer is much less. So we figured that would be a good way to start. We did do O, universal compatibility. We did O positive, and we'll talk about that in the next slide. We decided on doing whole blood, right? Because it has all its components. You want to give back platelets. It's a major trauma patient. You don't want to just give packed RBCs. There are multiple agencies out there that are doing only packed RBCs. So there's different ways of doing this. We decided to do whole blood because we figured giving back all the components early was important. The problem with low titer O positive whole blood, or not problem, but issues that they have is that you have to store it between 1 to 6 degrees, right? They're very specific about the temperature, and the blood is only good for 21 days from collection. So we wanted to make sure if we are not using it, we don't want to waste this, because this is not easy to come by. There's no factory creating and producing low titer O positive whole blood. So we're very specific that we did not want to waste blood. So it's good for 21 days, and the blood bank tries to give it to us as fresh as possible. So Rh positive, why did we not go with O neg whole blood, right? So that is a challenging one that the media picked up on right away, and they were like, wait, why are they giving O positive? But what about all the women that are O negative or are going to be pregnant? And it's one of those things, we can talk about this in the medical community, and we can, bring out papers and articles, but having a reasonable soundbite to the media was a challenge, because they just see it as they're doing O positive instead of O negative. That is not the universal donor. So you have to think about things that are outside of the medicine as well, which was a little bit challenging, because when we started this program, there was a few news reports that ran what we were doing and followed our crews. And it was a media kind of sensation initially when we did it. So you have to think about that. So there have been multiple studies, mostly within the last two to 3 years, that show that it's not as bad, right? And of course, I wrote down numbers here, and I can't read my own handwriting. But if you wanted to get O negative for everybody, it's near darn impossible, because the number of people that are O negative is so few, right? You're talk about 8% of the population, and how many of these people are donating. Like, to actually get O negative blood and make sure that you give everybody O negative, it's just not a feasible option. 40% of your population is going to be O positive, and they're the most likely that are going to donate. So your O positive coffers are definitely going to be more robust than O negative. The logistics of giving O positive is easier. There is going to be less ABO incompatibility with your O positive, right? The biggest risk is your alloimmunization in your Rh negative patients, right? Either if they're pregnant or if they have risk of future pregnancies. though the risk, there's been multiple studies and all the risk percentage ranges from 0 to 6%. There was one that even said was like 0.3%. It's a little bit all over the place, but still giving this gives you back your platelets, right? And the fact of the matter is they did an entire paper, and that was an interesting paper in transfusion medicine on the ethical consideration of using this. And they said, yes, I mean, you're looking at anywhere between 0.3 to 6% with versus a 24% mortality. So would you rather die because of traumatic hemorrhage for a less than 5% risk of alloimmunization in a small percentage of people? Maybe not. And there's a lot of factors that go into it. At what age are you getting it? How many pregnancies are you planning? What is the blood type of your spouse? Like, there's so many different things that are involved in this that the overall risk of alloimmunization is probably not as high as the risk of, or is nowhere near as high as the risk of if you were going to die from your traumatic hemorrhage. So most places that are using whole blood are using O positive whole blood for their patients. There was a survey study that was the last one. They actually surveyed alloimmunized mothers and asked them, hey, would you have been okay with getting blood, even if you knew there was a risk of alloimmunization? And they said, yeah, absolutely. If it would save my life, I would rather get the blood and then figure it out later. But this also puts the onus on the hospital to kind of follow these patients, to inform them of this risk and get blood testing done once in a while to kind of follow them. And many of the O positive pre-hospital whole blood studies, that's what they're doing. They're following them to kind of establish that risk because the percentages are not well published. So there is evidence, right? And there have been observational studies, and we have seen improved survival. We have seen reduction in additional blood products in the hospital. That was another huge one. So New Orleans, they published a study where they said their overall rates of using blood was low compared to what it was before they started the pre-hospital blood transfusion program. And if it's going to save blood on the back end, absolutely, it's a good idea. There is the hemostatic benefit, and it seems to be safe and feasible if we can get to them on time. I think that's the hard part. So we got to the question of, okay, how are we going to get it to them in a reasonable time? How are we going to store it? How are we going to move this? So this is the stuff that we used. We used a Credo ProMed transport cooler. Now, the Credo ProMed transport cooler is basically a glorified Yeti box that is paramedic safe. They can drop it and throw it around and nothing happens. So that's just, it comes with like a hard case insert in it. We threw it around, made sure it didn't break. I mean, eventually we can break everything. We are EMS, we are good at that, and we will do that. So yes, you can, but not as easily breakable as some of the others. So that's what we use to transport. This temperature log indicator, the temp sticks that we used, initially we did not start off with that. We started off with something else, and we graduated to this because this has Bluetooth capability, and it gives you the temperature monitoring within that cooler to your phone. And we can make sure at any given time it stayed between 2 to 6 degrees. Our cooler carries only 2 units of blood. So we did not buy a bigger cooler for multiple reasons. We weren't sure how much blood we were going to use, one. We wanted to make sure that it was easily transportable and to be able to carry on scene. We didn't want them to carry anything bigger. This was like our trial start. Let's see how this goes. So it houses only 2 units. The blood temperature indicators was our blood bank. They were like, we know this is, first they said, well, you have this temperature log. Can you validate it? So 2 or 3 days, we kept going around everywhere, left it everywhere, and showed them, yes, it stays within 2 to 6 degrees. And they were like, yeah, but just for safeguard, we're going to put these indicators on there. So if the indicators stay green, then we know. If the indicators change color, then we know it's not good. And we're like, fine. So they put the temperature indicators on there as well. But that's basically what we use to house and move our blood. It's fairly simple. If you guys have questions, you can totally ask in the middle. So how do we give it? The LifeFlow Plus is basically our rapid infuser that we invested and bought. So it's a push-pull mechanism. It's a syringe inserted. So every time you pull that trigger, it kind of sucks blood in and pushes it in. And with this push-pull, that we have to just be very cognizant and not say life flow gun, which is what everybody was saying. And on a trauma scene, that just does not look good when they say, hey, pass me the gun. So we were very specific about saying, hey, please say rapid infuser. And it's easy enough to use. It just takes some muscle memory as to how fast you're pumping. You don't want to pump it too fast. You don't want to pump it too slow. But with the rapid infuser, we can get a unit of blood in to a patient anywhere under 2 to 4 minutes. Setting up takes more time than it does to infuse the blood. So it's really fast. We did invest in the Q1 Flow Warrior Lite. That is probably,
How long does it take to set up?
depends on how good you are. So less than, so if it's a paramedic who's done it multiple times and is like that, under a minute, maximum 2. But if it's somebody who is like new at it and is fluffing around with the equipment, it might take them 2 to 3 minutes, but still not bad. So essentially what they do is when they come on scene, there's already fire and already probably a transport unit. They kind of package the patient while these guys are setting it up inside the ambulance, ideally, put them into the ambulance and start it right away, and they start infusing. But 9 times out of 10, 2 units are in before they even reach the hospital. And if they get to scene first, we've had a couple where they just start on scene and they just give the blood because they're still waiting on a transport unit and none was available.
Does it have any warming mechanism in it?
So that's the fluid warmer. So we did invest in the fluid warmer. This one doesn't have any warming mechanism. Some places do it without the fluid warmer. We decided we wanted to do it with the fluid warmer because we were just like, hypothermia and trauma it's not a good look. That was probably the most expensive of our setup because we have to think about cost and logistics as well. And we basically did all this with trauma grant money to start like our state trauma grant money, but that was the most expensive portion of this entire thing. We did end up investing in that, and that basically, it's got a rechargeable battery, and the medic in the morning, first thing when they check in, they have to make sure the battery is, where it should be and switch it out if not. And it basically, inside that little black box are a ton of coils, but every time it goes through the coils, it gets it from 2 to 6 degrees to 37 to 38, just going through that. And it's faster than, you're in a hospital pump. Like there's no delay really. Like while you're pushing here, the whole thing happens within 2 to 5. So it's really fast, really efficient. They use a version of this in the military. So again, rugged enough. Of course, we tell them never ever to throw this around because it's not cheap and we can't afford it.
Is there any concern for cell lysis with that rapid push-pull method?
So it will let you do it only like, you can't go any faster than. So what happens is if you try to do it too fast, the IV infiltrates. Or like it just doesn't. So with that, there has not been, and the Life Flow folks showed us their data for it. But I mean, we have not looked for cell lysis, but they showed us their data, and as long as it's done at an optimal pace, it seems to be okay.
And actually, these are both blunt and penetrating trauma patients.
We're doing both blunt and penetrating.
Any limitation for PEEP?
Yes and no. No, well, so no is the right answer. There is no limitation for peds. The only limitation was us because of our initial protocols. We did it only for adults, but we're expanding out into peds. So there's no physical limitation for peds. You just have to, because your IVs are smaller, you're just like the push-pull might not, like if you're using it, it's going to be like the amount of pressure that you apply on it is going to be a little less. But actually our PEDS hospital, CHOA, which is Children's Healthcare of Atlanta, they are participating in the MATIC 2 trial from the ED, and they are purchasing the same LifeFlow mechanism to give it in the ER because they are not doing whole blood in the ER while the adults get whole blood in the ER. So they're a completely separate entity. In Atlanta, it's a little bit different. It's adults and peds are separate. But so they're purchasing the same thing. So it's going to be easier translation from pre-hospital to hospital. So in addition to blood, we created kits for the QRV medic. So that was for the blood, but we were like, okay, with that, you need to carry other stuff. So equipment that you need to give blood, your advanced airway, hemorrhage control, what do you need to dress the wound, right? And any kind of meds. So we actually put in TXA, analgesia, and calcium. So a couple of things about this. Advanced airway, we realized, like, how AHA went to CAB instead of ABC, we realized that we're using less airway. These people are waking up and they're fighting us more. They are like their hemodynamic status is improving so rapidly. The paramedics were extraordinarily surprised for the first at least 2 to 3 weeks. I called every single one that had given blood, and they would be like, oh my gosh, it was literally like resurrection. Like they would wake up or they would start screaming in pain. And so it was a good thing that we put in pain medication, but we did not think of putting in sedation medication initial round. We realized that was a big mistake. So we put in restraints and sedation medication as well, because these people were getting up and fighting them because they were going from almost dead to back up. So that's something that we had to learn. We did have dressings and tourniquets, and because at the end of the day, it is a bucket that is leaking. You have to do two things, right? You have to plug the hole and refill the bucket, ideally with whatever was in the bucket, not dilute it. And you have to plug the hole, which is fine if it's in an extremity because you can put a tourniquet or put a dressing. But if it's anything central or junctional, you're kind of stuck. You need the OR for that. We can't do anything pre-hospital. We did decide to give TXA and calcium in the field. TXA, the surgical department was like, absolutely, yes, we are happy for you guys to give TXA. Pediatrics, they don't want us to give TXA. I was like, fine, that's whatever is easiest. But for us, anybody 15 and above is who go to the adult hospital. And we are doing calcium as well. There is no benefit to, I mean, there have been no studies that show that early calcium administration is going to help. There's nothing on the timing, but we're giving TXA, we can give calcium as well. And the good thing is once we started the blood, their veins started popping back up and it was easy to get a second IV to go ahead and give the TXA and calcium. So we didn't have to pause the blood to kind of infuse that. It made life a lot easier. We made our criteria as simple as possible. We were like, we have to keep this as easy as we can. We started with above 15, only reason being if it is 15 and above, they go to our adult trauma center and we know they're coming to us. Systolic less than 90. We thought about putting a heart rate in there. We were like, forget it. Let's just stick to 1. Systolic less than 90. And it has to be, a traumatic cause. And you see blood or you're concerned about internal bleeding. And we did say we would give it for EMS witness trauma or traumatic arrests. I'm not sure yet because we have to look at our data and see what the survival is for these patients, whether we should be giving them blood or not. The data hasn't said one way or the other because we don't have as many. But as of this point, if EMS sees them arrest, we are giving it. Of course, we excluded people who might not want blood if they already have an advance directive or they have another reason for shock. So most commonly, they either have a tension pneumo or something else that's causing them to be hypotensive and not necessarily just blood loss. So we're like, please fix that. And giving them blood is not going to change. They have to obtain early access, right? And they can get an IV or an IO. Can you use the rapid infuser with an IO? Yes, you can. Ideally, IV works better. So we prefer an IV if they can. We have to have the 2 provider cross-check. They have to visualize it, look for clot sediment. We train them to look at these blood bags and make sure that they, put down the bag numbers and we have all the paperwork in that same Yeti box, the Credo cooler. And they have to do continuous monitoring as they would for any trauma patient. And more often than not, it's the paramedic who's giving it. The paramedic jumps in with the patient and continues to transport to the hospital. And if their blood pressure improves, great. Just keep your permissive hypertension in mind. And if you give 2 units and they're still tanking and you need something more, we can go ahead and start the pasta water and to hold them in place until we get to the hospital. But try not to give a ton of saline or LR was the whole kind of concept. We would give 1 unit of blood, TXA, 2nd unit of blood if indicated, calcium, and hopefully by then you're at the hospital. So it's a reasonably simple, straightforward protocol. So we educated them about transfusion reactions in the field, what to do. And for the first, well, actually not for the first few months, even now, if they have any issues in the field, they call me. We have to date not had anything where they were concerned or any kind of transfusion reaction. So far, there was once a patient was like, I'm feeling really, really cold. And the medic realized that they had not connected the warmer appropriately. And they fixed that and was fine. but we really have not had any issues with transfusion reactions, but we do train them and what to do and what to give or to stop and to call us. How we deployed this, we have quick response vehicles. We already had them like kind of during the pandemic, and these are paramedics that are jumping calls for really critical patients to make sure that if there's only an advanced EMT, if they're okay, if they need any additional help. So we basically put the blood in these QRVs. So 3 QRVs for Atlanta, 1 QRV for South Fulton. And we basically said, if you hear a trauma call, or we also told our dispatch if they fall under these codes, call them, let them know, and they would just head on to scene directly. Many a time they get there before the paramedics even get there. It's luck of the draw who gets there first, but everybody kind of gets to the same place. And once they get there, they get into the back of the ambulance, which makes it an ALS ambulance. They get all their equipment. They go ahead and start blood. They transport the patient, and one of the other personnel just drive their QRV back to the hospital. Our blood return process, so we did not, and this was something that I said up front, if we waste blood, they will never give us blood again. So we want to make sure we don't waste blood. So we set up an artificial expiration date for ourselves. It lasts for 3 weeks. So we said at the 2-week mark from collection is our expiration. So if they gave it to us as soon as it was collected, we had 2 weeks. If they gave it to us 1 week after collection, we had only 1 week, but we had an artificial date put on top. And on that artificial date, we would give it back to the blood bank, and they would just use it in the ER or in the ORs so that it did not get wasted. I think it's harder for a non-hospital-based system because they're not able to flip that back to their blood bank or whoever they're getting it from. In a hospital-based system, because we got it from the hospital, we were giving it back to the hospital, it was easier. But I think any successful program needs to have some mechanism of flipping that back so that you don't waste it. So we coordinated with the blood bank, and they made sure all our processes were in line to make sure the blood that we're getting back was the same. There was no loss of integrity there. And we established that time frame. They were comfortable with that. We had a training mechanism and tracking mechanism where the medic first thing in the morning would check the expiration, and if they needed to flip it out, they would flip it out. And what they did was, when you transport the patient to the hospital, if you've given 1 unit, you give the patient handoff, go straight up to the blood bank and replace an additional unit. Or if you give both units, go up to the blood bank, they will immediately swap out and give you 2 more units, and you're back on the street. I was worried that process would take too long, but I mean, it was straightforward. We went up to the window, and if they saw EMS, they would prioritize us. They would get us and flip out and give us 2 units and give us the new paperwork, and they would be on the road. The only thing that the EMS staff had to do is when they handed out the patient, the attending would have to sign off on their form so that they could take the form upstairs. Who do we train? Paramedics. So this is where Minnesota differs a little bit from Georgia. In Georgia, it is not scope of practice to give blood. Essentially, it is a post-licensure skill. So which means that if you want to do that, you have to apply for a post-licensure skill, and you have to show the state what your training program is going to be, and all your training materials. And a medical director has to be involved in training skill set, checking them off, and we have to sign that off within the state, and we have to do annual competencies. So not everybody can do it. I think, Anu, you guys can all, like, if you decide, you can do it. There's no specific scope of practice, correct? No state scope of
The
practice,
national scope of practice is our floor.
which is awesome. So the world is your oyster. You can do what you want. So, I mean, it's like we cannot do RSI in Georgia. Paramedics cannot do RSI. So it just depends. Every state is going to be different. So if you're starting this, check with your state scope of practice and rules and regs. But EMS is interesting because every state has its own kind of flavor. So we trained them, certified them, and basically credentialed them. Now, if this paramedic goes to another agency, they cannot give blood. They have to be credentialed and trained by that agency. So they can only do it with where they work. And our initial round, we trained around 75, and that included fire and EMS and some people who are not going to be on that QRV, because we recognize that when everybody goes to a trauma scene, you need help. This is not a one-man job. And so we cross-trained a lot of people so that they were able to kind of, even if they're not transfusing, help set up, pass the right equipment. When people say, hey, can you pass me this? They know what you're talking about, because, I mean, even in the ER, trauma resuscitation is not a single man job. It's a team effort, as it is outside of the hospitals. This was kind of our training outline, and fire, EMS. They were all, excited about that. I don't know why. Now that the pictures are blown up, that's one of our EMS fellows who's trying to reconstruct our mannequin that that got broken during one of the resuscitations, I guess. But we started off with them using it, explaining everything. They got to play with individual equipment, and we had like this big moulage scene where we had somebody that was spurting out blood, and they would come and try to fix this mannequin. And we wanted it all to be kind of like a NASCAR pit crew approach to how they managed the trauma. Documentation and handoff, there were regulations. There are regulations. Keep in mind anything to do with the blood bank does have paperwork and regulations, and we want to follow them. We want to follow them because we want them to give us blood when we need it. And we want to make sure this program continues. So the FDA does require that every unit of blood that is given be signed off by a physician. Most of the time, when we go to the hospital, the attending who's receiving signs off on it. So far, we have not gone to other hospitals, but we are starting our PEDS program, so they will be going to CHOA. So what we have planned to do is, yes, the receiving CHOA attending will sign off on it, but I'm going to have to go into the chart and additionally do like an attestation or sign off. And it's basically saying that it was needed in this patient, but you have to make sure you follow the protocols and the guidelines. Hospital pre-notification, let them know that they're getting that, right? And we started off doing stat packs. We kept a bunch of stat packs. I'm guessing we do stat packs here still. Yeah, so we put a bunch of stat packs in the ambulance, and we started taking that, and we realized that was a dumb idea because we would go to the hospital, they would have already created yet another stat pack. All we were doing is 20, there was duplication. There were 2 different stat packs floating around for the same patient. We were like, we're just going to stop. We will give you the paperwork. You create your stat pack and put it in. So figure out what works for your system, but make sure there's a proper handoff and proper pre-notification. And this is going to be even more important for us in PEDS, because in PEDS, a lot of times there's no PD blood bags. It's still the same blood bag. So if you're giving only half of it, we don't want them to throw out the rest. We want them to be able to use it. So we want to make sure we relay that to them. So our patient, 2 penetrating wounds, left thigh, 1 to the left chest. We had the tourniquet, chest seal, initial vital signs, 88/56, was an hemorrhagic shock. Heart rate was 120, respiratory rate 20. And GCS was 15, but he was like lethargic and like getting to where he was not talking slowly. He was tachycardic, diaphoretic, tachypneic, hypotensive, and he did have clear breath sounds bilaterally on initial exam. So they initially bleeding controlled. They put them in the back of the truck so that they wouldn't get cold outside. They managed to get IV access. And within 6 minutes from time of patient contact by the QRV medic, they had already received their first unit of blood, TXA, and some fentanyl, because by then he was more awake and screaming in pain. Medic, super proud of her, reassessed the patient and was like, oh, this patient is still hypotensive and SATs are going down. And rather than just starting a second bag, assessed and realized that they now had a tension on one side, needled that, the blood pressure improved, hypoxia improved, didn't need any additional blood, managed to take them to the hospital and then on to the operating room. So, it's one of those things we need to remind them, hey, just once you start, it's not like I have to give everything. Make sure you reassess your patient, and that's really important. We were able to get them off scene in 14 minutes, which is huge. Early stabilization with blood and TXA, went up with trauma. There were multiple services involved with this guy. He ended up having a left hemo, needed a chest tube, had some retained ballistic there, had a second rib fracture, eventually resolved. Orthopedics came in for that distal femur fracture because he had a ballistic wound, operative fixation for that. Vascular service was involved, had a popliteal injury and had to be ligated for that. So a lot of things. He was in the hospital for a while and went home, awake, alert, walkie-talkie. So it was great outcome. And these are not the patients that would want to advertise and say, hey, Grady gave me blood and saved my life, because, they started off with a GSW. They probably don't want to be on national news. But lessons we learned, a lot of lessons, right? Patient response, we talked about this, anticipating that change in mentation. We did not think it would be so radical. And we started putting ketamine and Versed and Haldol in the trucks in that kit so that they were able to sedate them. Airway management, we were needing less airway management. They were actually waking up. We didn't have to intubate these patients. We didn't have to bag them. Initially, it was challenging for single providers, so the cross-training really helped. There was some of that light flow troubleshooting because if you push it too hard, you can infiltrate an IV, but repetition is key. We had it over and over for them to, and we haven't seen those issues except for that first two weeks. And that was the same, the IV infiltration, loss of access. The blood unit supply, it was one of those things we had to estimate how much blood we would need, because at the end of the day, when you go to the blood bank, they're going to be like, so how many units do you think you're going to use? And we're like, well, we don't know, because this is the first time we're doing a program like this. And so it was, they were super sweet to play along and say, okay, let's just see how it goes. But if we need it in the hospital, we'll pull it away from you guys. And we're like, yeah, that's understandable. And we stopped our pre-registration and indication. So now I get calls in the middle of the night. It's like, we've got this guy with a huge GI bleed. He's vomited so much blood. Can we give blood? We need blood. At this point, our protocols and our guidelines are only for trauma, but we're expanding that to pediatric trauma next. That's starting December 17th, I think, or 18th. And after that, the hope is to move on to medical, depending on the need. But we don't want to, exhaust the blood bank as well. We want to make sure we use as much as we need. So our data, and again, this is preliminary data because we started in March, end of March, and already we've given blood to 273 patients. I don't know what that says about Atlanta when we say traumatic injury. I moved from Rochester, Minnesota to Atlanta, and those are some staggering numbers. Our average age is a little bit higher than I thought it was going to be. I don't know, I thought 37 was a little high, but okay. 83% male. Shocker. No, not really. And we've given 429 units of blood. This is as of Friday. I didn't check on Monday. 10% of those were traumatic arrests. We don't have enough traumatic arrests yet for me to say, oh, it's worth it or not. And at the time of first blood administration, our average systolic was 70s. And at time of transfer, it improved to 100. So a 20-point improvement in blood pressure, which makes it easier for EM to go ahead and put them in the scanner or get them up to the OR and gives them more time, as opposed to like saying, oh, I can't do anything right now because we need to stabilize. So they're coming to the hospital in a hemodynamically much better place. Units transfused, most people got 2 units. Many got 1, so it was like 52-45 kind of split. And the others, some people ended up getting 3 and 4 units only because 2 QRVs responded at the same time, knowing that it was going to be a major trauma. And there was another one that was free, and they ended up having 4 units and seen if needed. Most of ours was 66% of ours was penetrating, big orange, 29% blunt, and the 5% other is either the GI bleed that they randomly called me about at 2 a.m. and I was like, fine, or there was one that was a postpartum hemorrhage. So it's different other things. And this is super preliminary. We have not done any propensity matching to compare to previous years, but we gave TXA 216 times, calcium 105 times. We are closely monitoring our mean scene time, and our mean scene time, barring extrication delays, was around 20 minutes. And some of these is because they have not documented if there was an extrication delay. A lot of these major traumas, there are extrication delays. And again, data is only going to be as good as the information put in. We need to remember that. Our MTP use has gone down over after we started the program, which is good. And most of our patients, 123 of them ended up going up to the OR right away from the ER, and some to angio. Quite a few got discharged. And if I add all that up, it's 74% that was successfully discharged from the hospital, as opposed to before that was a little less than 50, or it was around 50%. So significant improvement in mortality. But again, it's only been a few months. It's hard to like extrapolate that. But everything that we're seeing is positive. But to get your statistical significance, we will still need some more. And what we are hoping to do is kind of matching this to similar patients before we started blood, because it's hard for anybody to do a randomized control trial. And we talked about this in Journal Club yesterday, right? How much are you going to do? Like we were talking about injecting joints with saline. Like we can't really say, oh yeah, we're going to give blood in this person and not blood in this person. And any trial in EMS is going to be hard because you're doing it as an EFIC trial. There's no way to get consent. There is no way. I mean, it's an emergency situation. You're doing exception from informed consent for these. So there's a certain amount of ethical, like what can you do, what can't you do? But there are some places that are trying to compare, and our hope is to compare before and after. So our data seems super positive. Our survival rates, both at 24 hours and 30 days, is much higher than it was. And our MTP utilization, I wrote this down. I think over the year before it was 100 and something, and it went down to 70 something. So we are seeing a decrease in the amount of MTP activations once it came to the hospital, 112 to 70. So from 23 to 24, and we're just talking about half of 24, right? We're not talking about all of 24. So if we're going to save overall blood by giving it earlier, I think it's worth it. Despite this limited adoption nationally, less than 1% of the agencies have successfully implemented this. I mean, we know that there's quite a few patients that can benefit from this. Why have they not implemented this? National challenges, right? Many states scope of practice limitations. Many states don't allow you to give blood as a paramedic. They're still working through their national scope of practice committees to kind of get it authorized. The availability of blood, where are they getting blood from? Some of these private agencies, they'd have to liaise with Red Cross or some other independent agency to get that blood, which can be challenging. Program cost. Setting this up is not easy. Once it's set up, it's fairly reasonable, but you still have to get some kind of grant or invest in the equipment. There is so far no centralized data or collection process to kind of justify this as yet, because everybody's like still in the starting phases. And there has to be a lot of collaboration, right? This is not just an EMS thing. It's EMS, EM, transfusion medicine, trauma surgery. There's a lot of people that are involved in this, and it has to be everybody in a room talking together and being on the same page to get something like this started. But I think one of the biggest issues that we don't talk about, elephant in the room, is reimbursement. Who's paying for this blood? So EMS, we're eons, years, centuries behind for reimbursement. We used to get reimbursed only if we transported a patient, and now we get reimbursed if it's ALS or BLS. So there's no real, we don't get reimbursed for everything that we do. So if we give blood, who's giving us money back for this blood that we've given? Nobody. It has finally passed through CMS that blood falls under one of the ALS kind of buckets. So before, if you had to get ALS level of reimbursement, which is still peanuts, by the way, but if you were to get ALS level of reimbursement, you either had to intubate, there was a group of things, and now they've added blood to it. So that's baby step. How we got around it is we're a hospital-based system. They're being transported to the hospital. It gets billed with the hospital. If we transport to a separate hospital, we'd have to write it off as a loss for now, because a separate healthcare system is not going to bill us for this or pay us for this. So a lot of private hospitals and a lot of private agencies, that is the challenge. So it depends on it's getting there. They are nationally fighting for this. And it will get there. It's a matter of time. Unfortunately, the medicine is ahead of administration. So, you got to see if this is going to work for your system. If there is a need, first of all, if there is a need, what are your barriers and how would you address these barriers? But I think the medicine behind it and the clinical, there is clinical sense to doing this. But again, logistically, every system is going to be different. I think that's all I have. This is actually close to my house. I was surprised when I saw that. But yes, this is Atlanta. Apparently, this is where the players play, along with Taylor Swift. I was working in the ER for the Taylor Swift concert. It was not fun. I wish I wasn't. And Beyonce came at the same time. Yes, Atlanta, we have a lot of events. We actually, Anu talked about medical direction for the Publix Marathon. I also, but even bigger than that, I'm the medical director for the Peachtree Road Race. If anybody's into running, no. So it's the largest 10K, and it is bizarre because there are 65,000 runners, and they cap it off at 65,000.
Wow.
65,000 runners for a 10K on 4th of July in Atlanta. if anybody enjoys running and wants to put themselves through punishment, you should totally do that. It's fun. I mean, there's the official race people who hand out water and keep you hydrated, and there's the unofficial people who are on the side who hand out shot glasses. And there's Jello shots apparently on. It's an interesting race, and we see an annual ED volume in hours in our medical tent and get flooded. But anyways, questions. Sorry, I digress.
First, thank you.
Thank you.
Yes, sir.
Dr. Kumar, thank you very much for a really brilliant presentation. I'm David Toure and the Trauma Program here. I think it makes sense that the resource gets delivered as close to the scene of the incident as possible. You know, the Israelis taught us that if you just train taxi drivers to give blood right when, you know, at the scene of an explosion, they do better. The British and the Japanese are right now working on perfecting Reboa for source control right at the scene of a traumatic injury. I think, what you are trying to accomplish and your colleagues certainly makes sense. And I really applaud you for that. This is it's a heroic effort, and lots of, people have to be convinced, and it sounds like you're doing a good job trying to draw these folks in. I have a couple questions. One is, what is your, and this could be maybe even called a fifth pillar or an expansion of your fourth pillar. What is the process in place to query each of these activities, once they've happened? So all the transfusions that went out, who did they go out to? Does somebody go back and review?
Oh yeah.
Where the indications truly met? Because, as you and I know, I mean, I applaud the paramedics. I mean, these guys go to school for a few months and they do so many things. I went to school forever and I still confuse on a very good day. And, how do you recognize somebody that's in shock? And when do you know this is the right person to give it to versus the person that may not really benefit from it? So that's my first question. Second question is, how were you able to get through how were you able to convince your blood banks that doing whole blood makes sense? And I'm seeing this in with respect to, you get donations are down nationwide. It's hard to get blood. They could get a unit and burst it into PRBC, plasma, cryo, and make a lot more money out of it versus just packaging it into one package, and call it low titer, local reduced blood, and perhaps not be able to make, so how were you able to get that conversation off the ground to a point where they can understand that this really means something?
So first question, we actually have a QA/QI process. And I started off saying I was going to review 100% of every unit administered as to indications. And every Thursday morning at 10 o'clock, we have a meeting with the QA officer and we go through every single chart. And I did not expect those volumes. My schedule just infinitely exploded, and it is a pain in the behind, but I have been doing it until now. And surprisingly, all of them met criteria. Some of them, I'm like, even if they had not gotten it, they might have made it. Like if you have an extremity injury that ended up getting a tourniquet, and maybe a little bit of saline would have improved their blood pressure and they might not have needed blood, but they did get blood, but they fit the criteria that we set out. So they, on paper, yes, they were indicated, but there were no inappropriate admissions of administration of blood. There was maybe one or two where I was like, it was like close to 90, but then, or it was right at 90, but then clinically the patient looked like they were in hemorrhagic shock, because we taught them, hey, it's not just don't go purely by the numbers, you have to consider the whole patient. But almost all of these were indicated, surprisingly, because when I saw this kind of numbers pouring in, that was my thing. I was like, do we really need this much blood? Because this seems like a lot, but surprisingly, we have been giving it appropriately. The blood bank convincing portion of it was a little easier for me because they were already doing it in the ER. So the ER was already housing whole blood in a kiosk in the trauma bay, and they had already, the surgeons and the blood bank were on the same page. So for me, it was easier to walk in and say, let's extend that. So I did not fight those initial battles for having whole blood for trauma patients in the ER. So I don't really know about that portion, but I know that our surgeons did.
Sorry to interrupt. I'm just saying in regards to, I mean, here on a good day, if I really want to give whole blood, there might be a couple units available. And I am certain if I work the lines up the chain to find out why do we have 40 units of whole blood, now you're given, dozens a day, maybe hundreds a month. That is a huge, huge commitment. And part of the difficulty, and I completely agree with you that, whole blood makes sense from, for all the reasons you mentioned. But there's a huge amount of data that hasn't really been able to justify it. And partly is because if I give a unit of whole blood and then I give 20 units of punctured blood cells, will I really see an advantage? I mean, the delusional effect of everything else will just totally outweigh that. So I'm just thinking about it from a bigger scale. You upscale it, and you're telling your supplier, Livestream or Red Cross or whoever, and say you're going to shift production to a huge amount of whole blood, which I here even at the Mayo Clinic, that is a challenge.
Well, but they were already getting the whole blood for the hospital, right? So we were taking that whole blood and we were able to show that we're using less in the hospital. That is why I'm really hesitant while the paramedics keep saying, oh, we need to expand this to medical and we need to, I'm like, I don't know, because I'm scared that if we did and we had more volume, we would have to shut it down. So while I see the benefit, I also don't want to scale up for the very same reason that you're saying, because in this population, we know that it's helping. I don't have data to show that it's going to help as much in all the other population, or, it's hard. I don't know if that demand supply chain is going to work as well. But our goal is to show that your overall transfusion rates are lower, and that's why we are justifying our presence and existence of doing it this way. I was going to say one more thing and I forgot. Sorry, escaped my mind. But I can, the drives. So we actually, because we were using so much, we set up an EMS ER, like a pre-hospital blood drive. And we kind of competed pre-hospital, in hospital to like on 9/11 to donate blood, and all of us try to, especially to kind of show them, hey, we're committed to this program, and we try to host a blood drive, and we were super involved in that as well. But supply is not easy, especially after the pandemic. And we were in no uncertain terms told that if the hospital needed it and surgery required it, we would be the first ones that they would pull it from.
I've got maybe a little logistics question that this is the kind of thing that an EMS physician would ask. You're using these response vehicles, these quick response vehicles, are they being dispatched based on your ProQA determinant codes, or are they just listening to the details? Okay.
Both.
And then the other side of that is, they're the ones that are administering the blood. Are they doing that during transport, i.e. jumping in the back of the ambulance? And then
So ProQA, we've identified the codes. I've gone through those 2,000 plus codes yet again. I swear, like my predecessor has done it twice in his 10 years, and I've done it 5 times because we keep introducing things in 2 years. But we've highlighted which ones they get auto dispatched for, and they also listen to the dispatch feed. They are really good about jumping these calls. This is a new thing, and one of the things that I have to say is after the pandemic, like the EMS morale was pretty low. This hugely improved their morale as well, because they felt like they could clinically see these changes, and it made them feel really good. And they are really on it about trying to jump these calls.
So this is just a comment about donation. I don't know if you guys know, but in Rochester, our fire department, our police department, and our EMS agency have a all-out war to see how many units they can all donate. And they try to convince each one of us to donate to a particular thing, so.
Yeah, you almost have to do it that way if we need to keep up the supplies. But Grady Blood Bank coordinates that collection from different sources. So we don't ever have to, we as EMS don't talk to any blood bank, right? We just get it from the hospital blood bank. It's a hospital blood bank that's kind of sourcing it, and they look at their supplies and they kind of decide how much they need and what they need. And we are a county hospital, and we are the safety net. So it's an interesting kind of set. So and somebody was asking me about the relationship. So I'm an Emory physician, but like all the Emory physicians also staff this massive county hospital. So it's a little bit, the logistics and processes are a little bit different.
I can chime in and say from the transfusion medicine standpoint, it's really great to kind of see the presentation and talk about the highlight of the collaboration between different groups because I think when it's a good idea wherever you guys go to get to know who's in charge of the blood bank at your institution, so you can reach out to them, help them understand what you're trying to accomplish. They can let you know what kinds of challenges they're running into, supporting that. You guys can figure out a lot of issues that come up along the way. And another part that I really like there is this like ongoing quality aspect to the program, because that's also something that blood banks really get challenged by, right? Like if we send out emergency release units, sometimes we follow up with physicians trying to get that signature that we need for regulatory reasons. And it's sometimes really pulling teeth and a challenge, which eats up a lot of resources and then puts us at regulatory risk. So this was a great presentation to kind of highlight that collaboration, and blood bankers are not inherently the no people.
Apparently not. I thought they were, and they were not. I was very surprised.
But that's where it's important to kind of have these relationships.
Absolutely. And our QA/QI, like when we do our quality assurance, the trauma data coordinator is also sitting in on those to give us outcome data so that we can pass that back to the paramedics. And we're adding those fields into our data so that we can try and see not just, because that's the other advantage of having a hospital-based system, you can kind of go out to the outcomes as well, which is harder if you transport to somewhere else.
Lakshmi, that was fantastic. Truly wonderful work to develop this program for the people of Atlanta. It's really inspiring what you've been doing and what you continue to do, and we wish you all the best. And to the listeners, thank you for staying with us. Thank you for tuning in the first place. It's the new year, and so we all have resolutions, and I'm going to ask if you could please resolve to like, comment, follow the show on whatever podcasting platform you're using, and also resolve to come back in February to check out the next chapter when it hits. Thank you for listening to our show.
The Always On EM Podcast.
Emergency Medicine Grand Rounds.